Okay, I guess we should start now.
Yes.
Okay. Yes. So we are starting with our session. Good evening, everyone. I am Abhinya Srivastava. Welcome you all to episode 9 on osteoporosis, organized by Stethify, the official podcast team of IMA MSN UP, on occasion of World Osteoporosis Day. Before we proceed with today's event, I would like to thank Dr. Rajnish sir, convener IMA MSN UP, Dr. Rahul Anand sir, General Secretary IMA MSN UP, organizing team Sneh, Sahani, Arjit, Bansal, Shashwat, Singh, an entire team of Stethify for organizing this wonderful event. My co-moderator Ananya will take care from this.
Thank you, Abhinya.
Ananya.
Hello, am I audible?
Yes,
Yes,
you are audible.
Thank you, Abhinya. From our head to our toes, from birth to old age, our bones are vitally important.
A bit louder.
They are the living tissue. Sorry. From our head to our toes, from birth to old age, our bones are vitally important. They are the living tissues that develop, strengthen, and replace themselves throughout the life. When this rebuilding phenomenon of our bones are hampered and they become fragile, we are bound to experience a hidden warning sign of the disease to develop, known as osteoporosis. This day, that is the 20th of October, is a day dedicated to discuss and learn about this disease. For this, I, Ananya Rajlakshmi, welcome the first guest, who is none other than Dr. Manoj Kr Choudhary, sir, the President of Bihar Orthopedic Association. Dr. Choudhary has done his MBBS from Patna Medical College, Bihar, and Diploma, MS and MCH in Orthopedics. He is currently serving as the head at Jawaharlal Nehru Medical College and Hospital in Bihar. He is the state representative and has been the National Executive Council member twice and is presently the President of Bihar Orthopedic Association. He has been conferred many awards like Dr. Number 1, Bihar Healthcare Excellence Award, IOA President's Award, to name a few. He has a keen interest in social work and runs a program, CAP, Community Awareness Program, to bring awareness in the population at large. So can we please have Dr. Manoj Kr Choudhary, sir?
Thank you. Thank you, Ananya.
Nice to hear.
Dear participants.
Welcome.
Hello.
Nice to hear that grand welcome, sir.
Thank you. Thank you. So, participants, dear participants, I welcome you at this webinar and thank the organizers from UP for giving us opportunity to interact with you. I am here not as a professor delivering lecture in classroom. Rather, I have come here as a guardian. You all are young and are as good as my sons and daughters. When the children grow up, they become friends. You must be remembering Prapteshu Shodasvarse Putram Mitram Acharet. In this way, you are my young friends. Today is World Osteoporosis Day. With this, a flash comes into our mind. Why at all osteoporosis is so important that a full day is allocated and it is observed worldwide. In fact, this is a household problem and should not have been so important. It's not it. But I am awfully sorry to say that this is not true. Osteoporosis causes morbidity more than any disease like hypertension, diabetes, which we know. In fact, it is the second most common disease after osteoarthritis in the world. If you search the data, if you see the data, you will find that it affects a majority of the population. For example, every one person in 5 persons is suffering from osteoporosis, and the condition of the female is still worse. Every one among the 3 is suffering from osteoporosis. So coming on to the silent epidemic. In past, we have faced many epidemics. Today, also, we are facing the challenges of COVID-19, and we are scared of it. Why? Because we find it detrimental to our health, life, and earnings. These epidemics gradually lose their fangs, and we forget them. One condition which from population silently steals health, makes life miserable, and there is loss of earnings is innocent looking osteoporosis. Like, or innocent, totally innocent. The clinical consequences of osteoporosis is fracture. We all know. And it has same effect on health, life, and earnings, just like epidemics. This is the story of every family, village, town, state, or a country. Nobody is spared. So this is called a silent epidemic. The National Osteoporosis Society of the United Kingdom took an initiative to bring awareness in society about the detrimental effect of osteoporosis. They conceived the idea of Osteoporosis Day. World Osteoporosis Day was launched on October 20th, 1996, and it is supported today also by European Council since 1997. The World Osteoporosis Day marks the year-long campaign dedicated for prevention, diagnosis, and treatment of osteoporosis worldwide. So what are the aims? World Osteoporosis Day is there, but what are the aims? The aims are to make osteoporosis and fracture prevention a global priority and to involve health professionals, policymakers, and public at large for this. Professor Cyrus Cooper, who is the president of International Professor Cyrus Cooper, who is the president of International Osteoporosis Foundation, he says, is of the view that World Osteoporosis Day is a key date in the bone field. It is an occasion when people around the globe unite to put the spotlight on immense global burden caused by osteoporosis. Now coming on to World Osteoporosis Day 2020 this year. This year, the campaign was launched in Russia on September 1st with traditional children drawing competition under the slogan, "My parents and I are a strong and healthy family." Now coming on to osteoporosis. We all know osteoporosis, what osteoporosis is, and the definition is, it is a genetic. Hello? Are you listening? So the definition is, it is a generic term referring to state of decreased mass per unit volume of mineralized bone. Coming on to the structure of bone, you all are doctors, you must be knowing. So there is nothing to say the structure of bone. Still, bone is a specialized connective tissue providing a rigid skeleton and gives all important shape to body. It is not merely a pile-up of calcium, rather simulates pillar of concrete, a mixture of cement, stone chips, and water. Similarly, bone has protein framework and calcium and minerals are deposited in it. The unit is called osteomes. And there are three types of osteomes. We all know osteoblasts are there that form the bone. Osteoclasts are there that remove the bone and help in remodeling of bone. And osteocytes are there. They are the resting cells. You know that bone has two constituents, cortex and medulla. Cortex is composed of compact bone. The bone lamellae are arranged in regular fashion around a system of branching canals with nutrient vessels inside. These branching canals are called Hallett canals and they communicate with the outer surface. Medulla is the softer counterpart. It is made up of loose network of bone trabeculae. It is storehouse of 95% of body calcium and other minerals. It contains bone marrow, which is the source of RBC and WBC. The stages of osteoporosis is there: normal bone, osteopenia, when there is some loss of bone matrix, and osteoporosis when the density comes down very low. This is the picture. This is the normal trabeculae, and this is below the osteoporotic trabeculae are there. You can find that the trabeculae have become very thin compared to normal bone. So decreased density. Why there is decreased density in osteoporosis? It is because of deficiency of protein matrix in which calcium is laid down. And rate of reabsorption, that is osteoclastic activity, is more than osteoplastic activity. Rate of bone formation is less than rate of reabsorption. Now DEXA are there for BMD test. So the DEXA criteria for osteoporosis as determined by WHO are BMD of spine and hip of 2 to 5 standard deviation below mean healthy women, that is T-score of -2.5 or below. And osteopenia, if it is between 1 to 2.5, -2.5 standard deviation or more mean. So in the population at large, we need to screen the population. So what can be the criteria for screening of population at large? Number one, all women above 65 years of age and all men above 70 years of age. But in selected post-menopausal women and men between 50 to 70 years with increased risk of factors or comorbidities can be screened. So I had said earlier that 1 in 5 men are suffering from osteoporosis and 1 in every 3 women are suffering from osteoporosis. Why this is so? Why women are more susceptible to osteoporosis? This is because of 6 Ds: diet, difficulties, drugs, day-to-day activities, deficiency of hormone estrogen, and dependence on culture and tradition. What are they? So coming on to the diet. First. So our society is a male-dominated society. In our society, women are deprived of healthy and balanced diet. The major portion of healthy diet is consumed by dominant male, and the female have to feed on their leftovers. So how can they get healthy food? Similarly, they have many difficulties. Most of the time they remain indoors. They cannot go outside. And in this way, they are deprived of vitamin D, and this leads to osteoporosis. Drugs. As they cannot go outside, they cannot go to hospitals and meet the doctors. So most of the times for minor ailments, they contact local people, the quacks, who infrequently prescribe steroids. They are in habit of prescribing steroids. And these steroids cause tremendous osteoporosis. Day-to-day activities. The women are engaged in day-to-day activities and do not get time to spare for themselves, for their health. They cannot do morning walks. They cannot go outside for morning walks. They cannot do yogas, exercises. And in this way, they fall prey of osteoporosis. Deficiency of hormone estrogen is a physiological problem, but this has to face all women. We know that estrogen is very important for osteoblastic activity. So this deficiency of hormone estrogen causes osteoporosis. One estimate is there that after menopause, 1% bone loss, BMD loss is there per year. In fact, this looks very small, too little, 1% only. But if you find a woman of 70 years, she has to lose approximately 25% of her BMD. So this is a lot. And now coming on to 6D, that is the dependence on culture and traditions. What is our culture and tradition? The women will feed after every male member, and children will have their meals, number one. Number two, all the fastings are reserved for female in our society. So they have to do fastings frequently, and this leads to osteoporosis.
Okay, sir.
Now coming on to World Osteoporosis Day this year, 2020. This year's campaign has the features like reveal the human costs of fracture, encourage the public to check their personal risk by osteoporosis, improve understanding of the link between osteoporosis and broken bones, raise awareness of osteoporosis, urge healthcare authorities worldwide to implement post-fracture and secondary fracture prevention. What is this post-fracture and secondary fracture prevention? Actually, what happens, if a person suffers from one fracture, he is more prone to rather 60 to 70% more prone to refracture. So we have to give attention on such person who have suffered one fracture in their life and reveal the socio-economic burden of fracture on the person. Now coming on to the take-home message. What can be the take-home message? This is the normalcy leads to ignorance, and ignorance is bliss. If we do not know, we are very happy. If we are not aware, we are very happy. Normal people with point of view of a common person will tend to ignore a lot of small clinical features which medical point of view of a doctor would not. So it's important as a doctor, you all note it down that you all are doctors, that it is important as a doctor not to ignore anything. Keep looking for the signs and symptoms of osteoporosis in our society and kins, and we are sure to bring a change. Thank you.
Wonderful,
Thank you, sir, for this very informative session. Thank you, sir. Now I invite Abhinya to take over. Thank you.
Thank you, Ananya. And thank you, Dr. Manoj sir, for this session. It was really informative. Now, I would like to welcome Dr. Rohit Mohpal sir. Dr. Mohpal sir has presented paper and posters both in national and international.
Thank you very much for cordially inviting me for such a wonderful, awareness program. I think I'll start my presentation. I'll share my screen, right?
Sure, sir.
So, is it visible?
Yes, yes, sir. You are visible
Yes,
and
sir.
audible. Both.
Okay. Thank you, Manoj sir. So it was a wonderful presentation to hear. Good evening, friends. I'll be talking about osteoporosis, its clinical presentation and diagnosis. So the aim of my presentation would be to define osteoporosis, I think which has already been done by Manoj Choudhary sir. I'll also be talking about the clinical presentations that we as an orthopedic surgeons usually encounter and the investigations pertaining to osteoporosis. So by definition, osteoporosis is a systemic skeletal disease characterized by low bone density, a micro-architectural deterioration of bone tissue that enhances the bone fragility and increases the risk of fracture. Now, though it is written very simply, but then it is very difficult to understand exactly what it means. So for that purpose, WHO in 2008, WHO classified it based on the bone marrow density reports, that is the T-scores, wherein more than minus 1.0 was normal, minus 1.0 to minus 2.5 was considered osteopenia, and less than minus 2.5 was considered osteoporosis. And subsequently, a severe osteoporosis criteria was brought in, wherein less than minus 2.5 T-scores with the presence of fragility fracture was there. So the causes of osteoporosis are innumerable. But the most important that we talk about is the postmenopausal osteoporosis. The prevalence of osteoporosis and related fractures are higher in postmenopausal women than in older men, since estrogen plays a key role in maintaining bone health. Starting at an early age of 30, women tend to lose a small amount of bone every year as part of the natural aging process. At around menopause, with the decreasing estrogen levels, the rate of bone loss increases for about 8 to 10 years. Mind you, I'm talking about the rate, before returning to the premenopausal rates. What it means is the lifetime risk of fracture for a 60-year-old woman is usually close to 44%, nearly double the risk for a man of the same age, which is 25%. Secondary osteoporosis they are the other set of causes for osteoporosis, but there are too innumerable and too much detailed, and probably not worth this webinar. But still, I would like to bring a notice to two aspects of secondary osteoporosis. First is the glucocorticoids induced osteoporosis. See, what happens is we as orthopedic surgeons, as well as many physicians, we give glucocorticoids for various other ailments. And indiscriminate use of glucocorticoids tend to cause osteoporosis. And what happens is glucocorticoids, they block vitamin D action on calcium absorption and increase the bone resorption. Along with that, there is a depletion of osteoblast cell population and inhibition of the mature osteoblast function. And ultimately, osteoporosis happens. On the other hand, we have the chronic renal failure, which interestingly does cause vitamin D deficiency as well as calcium deficiency in the body. But the major reason for fractures in case of CKD patient is due to muscle weakness. Another set of reasons that causes osteoporosis are soft drinks, smoking, excessive alcohol consumptions. All of these three are known to cause osteoporosis. Quite recently, in many of the journals, they have started talking about vaping, and it has become a trend nowadays, but it leads to osteoporosis because of the high nicotine content in it. One of the major factors, or rather I would say one of the most important and the prime cause for osteoporosis is lack of exercise. When I talk about lack of exercise, I do not talk about a condition wherein, you know, at the age of 50 or 60 years, you're not doing exercises. Yes, that is important. But what I mean is lack of exercise early on, probably in your childhood, before the age of 25. What happens is at the age of 25 to 30 years, our human body achieves the peak bone mass. That is the maximum bone density or mass that we will ever achieve. After that, the bone mass tends to decrease. So if we have not done exercise before that, you know, we have not built up the bone mass, probably we'll have a low BMD later on in life. One of the prime example of this is we have many defense personals coming to our OPD at the age of say about 70 or 80 with having a very good bone density when we go for a DEXA scan, which is, you know, a great example for this particular scenario. So the clinical presentations for osteoporosis can be varied. The most common presentation that we have for osteoporosis is patients coming with these kind of fractures after a trivial fall, the hip as well as the spine. We have patients with generalized aches and pains, but more specifically low back pains at an advanced age. Then we have patients who come with these kind of report. This is basically a DEXA scan report. And patients have got it done from somewhere, and, you know, based on the routine package investigations in corporate hospitals, and they want to consult you regarding what to be done about this. And lastly, we have patients coming in our OPD, old age women with children's and grandchildren's concerned, why my grandmother is losing height. Last but not the least, the most important, I would say rather the most concerning cause of presentation is Dr. Google. So patients, they consult Dr. Google and they come back to us asking for the treatment for the particular ailment, which is very interesting. So as I was talking about the clinical presentation, diagnosis is based on clinical presentation. So most of the clinical presentation would give you a diagnosis, whether it is a primary postmenopausal, whether it is an aging osteoporosis, or is it a secondary osteoporosis. Important things are that we do require X-ray scans. What happens in the X-rays is we get pictures like this, wherein we have old ladies or old people having distal radius fractures in their forearm, people having innate vertebral fractures, and proximal hip fractures or proximal femur fractures. See, biochemical, another important set of investigation is biochemical tests, but the purpose of biochemical tests is to rule out secondary cause of osteoporosis, but not to diagnose osteoporosis. Obviously, the range of tests will depend on the severity of the disease, the age of presentation, and the presence or absence of fractures. The aim of this test is to exclude diseases that mimic osteoporosis, such as osteomalacia, multiple myeloma, identify the causes of osteoporosis and assess the risk of subsequent fractures, and most importantly, to decide what kind of treatment has to be given to such patients. So we have serum calciums, serum creatinines, vitamin D levels, and even serum protein electrophoresis for multiple myeloma. An important thing to consider for diagnosis of osteoporosis is a DEXA scan or a dual energy X-ray absorptiometer. What happens in a DEXA scan is two X-ray beams of different energy levels are aimed at the patient bone. A computer digitally subtracts or a software digitally subtracts the soft tissue absorption and gives out the bone mineral density level. This basically is determined by absorption of each beam by the bone and then calculating accordingly. The importance of DEXA scan is at least for this August gathering is to decide when to screen for osteoporosis. So a female patient of more than 65 years of age and a male patient of approximately more than 70 years of age, when they come to our OPD, DEXA scan should be routinely done. In patients of less than 65 years of age, there are presence of certain risk factors should be there to decide whether we need to go for DEXA scan or not. These include fragility factors after 40 years of age, parental hip fractures, medications with high risk of bone loss such as corticosteroids, smoking, alcohol, disorders associated with osteoporosis such as rheumatoid arthritis and ankylosing spondylitis, and low weight or major weight loss. So what I mean by this is that if these factors are not present in a person of less than 65 years of age, it is probably not useful to go for a DEXA scan. It produces controversial or varied results, and then it is useless. An important thing to consider, this is basically a DEXA scan report. So an important thing to consider here is what is a T-score or a Z-score and how is it significant? So a T-score is comparison of a person's bone density with that of a healthy 30-year-old person of the same sex. Whereas a Z-score is a comparison of a person's bone density with that of an average person of the same age and sex. So what it means is that in T-score we compare it with a 30-year-old individual who has a peak bone mass at that level. In Z-score we compare it with a person of the same age of the patient. So it is important to understand that the T-score is always considered to be a standard for measurement of osteoporosis. This is because when we talk about Z-score, we compare it with the same age. Therefore, for example, let's say about an 80-year-old, two 80-year-old patients having a Z-score of say 0. When it is compared with the other population, other patients of the same age has a Z-score of 0, but a T-score of -25. So a Z-score of 0 would probably not give you any advantage, any understanding. It will not make you understand anything, but a T-score of -2.5 will tell you, yes, this patient is having an osteoporosis, having a low bone density. An important factor to consider apart from bone mineral density is a fracture risk assessment tool. There are several clinical factors that are associated with the fracture risk that is greater than what can be accounted for bone mineral density. What it means is that bone mineral density alone cannot actually make us understand whether the person is liable to go get a fracture or not. So in this particular test, what we do is the aim is to provide an assessment tool, basically to provide an assessment tool for the prediction of fracture in men and women with the use of clinical risk factors with or without a bone mineral density report. So the benefit of this particular tool is that it calculates a 10-year probability of a major osteoporotic fracture occurring in the near future in any bone, rather in the proximal humerus, maybe in the proximal femur, any bone. This 10-year probability, it helps us to identify a subset of patients who are having osteopenia, meaning that they have a low bone mass but not osteoporosis yet, which are probably having a higher fracture risk and probably will benefit with osteoporotic treatment. So this is what a FRAC score looks like. And there are various risk factors apart from BMD, like advancing age. Obviously, age is an important factor. The patient of a greater age would have a low bone density. females as compared to males are, going to have a low bone density. Other factors include family history of fragility fractures, a low body weight, or alcohol abuser, previous osteoporotic fracture or previous fracture, use of glucocorticoids, and associated rheumatoid arthritis. I think this is a bit confusing. So what I mean is, see, the importance of a frac score is here. Suppose there's a woman with a T-score of minus 2.5, and the probability of a hip fracture is about 5 times higher in a patient of 80 years as compared to 50 years. So age becomes a very important factor. This is what I mean by these individual factors. And similarly, other factors also have their own bearings into the osteofracture risk. Another important investigations that we often talk about is bone markers. The bone markers are not very usually performed. We never perform bone markers ourselves, but we definitely, it's a topic of consideration. So most bone marker components are present not just in the bone but other tissue also, and so they will be ultimately influenced by non-skeletal processes. So changes in the bone markers are usually not disease specific. It is not that it is probably the because of the bones pathology only. But yes, they denote changes in bone metabolism, independent of any underlying cause. So we have two sets of bone markers for bone turnover, that is the bone formation markers and the bone resorption markers. There are many markers in both the groups, but there are two specific markers in each that we usually perform, especially in India. And I would like to tell you that it is probably available in major cities only, because they have more of a research purpose. They are right now used more of a research purpose and certain conditions that I'll be talking about to you. So we have the bone-specific alkaline phosphatase and the amino terminal propeptide of type 1 pro-collagens in bone formation markers, and C-telopeptide of collagen crosslinks and N-telopeptide of collagen crosslinks, that is the CTX and NTX in bone resorption markers. In India, we use CTX and NTX in the form of a urine assay to give a diagnosis. So the problem with bone markers is that, first of all, it has a very high cost. So it is probably not usable in our scenarios. Another factor is that it is dependent on the time of the day of collection, the diet, that is whether the patient is empty stomach or in full stomach, the activity level of the patient, seasonal variation, and even drugs that ultimately affect the marker assay. And also there has been a variability of approximately 10% in serum markers and 30% in urinary markers. So these are not very reliable tests to actually diagnose osteoporosis, but they are recommended for monitoring the effectiveness of therapy, predicting the response of therapy, and predicting the fracture risk. To summarize, as Manoj sir has very beautifully told, it is a silent killer. There is no doubt about that. The most common presentation is a fracture following a trivial trauma. Lack of exercise plays a major role in the development of osteoporosis. Blood tests are usually required not to diagnose, but find out the secondary causes. And DEXA scan along with frac scoring is important tool for diagnosing and planning of management. Thank you.
Thank you so much, sir, for the presentation. It was informative for me as well as our audience. Thank you again, sir. Ananya will continue from here. Yes, sir. Ananya.
Wonderful presentation, Rohit boss.
Thank you, Dr. Bill. Thank you, Dr. Rohit sir and Abhinya for this session. Moving on to our final speaker, please welcome Dr. Gyan Ranjan. He has completed his graduation from TD Medical College, Kerala, PG from MGM Medical College, Bihar, senior residency from Primus Super Speciality Hospital, New Delhi, and Charak Palekar Hospital, New Delhi, spine fellowship from Ganga Hospital, Coimbatore, and Indian Spinal Injury Center, New Delhi, clinical observership from National University Hospital, Singapore, fellowship from Marian Hospital, Germany. He has published 7 papers in various journals and has done more than 40 presentations at state, national, and international conferences. He has been awarded Dr. R. Ganguly Gold Medal Award at BOA Con 2020 at Betia. So, can we please have Dr. Gyan Ranjan, sir?
Much, Ananya. Thanks for the wonderful introduction. Actually, sometimes you don't believe it when people are talking this much. But thank you. It's so nice to hear. And my respected senior, so nice. When I see you young guys, which year are you in? Before I start, just 2 minutes, I'd like to ask you, which year are you pursuing right now?
I'm in second year.
Second year, very good. All your friends are mostly second year. You people are doing a fantabulous job. It's really impressive. We never did it when we were second year. Chalo, very good. Now we'll proceed. Now we'll proceed to like I'll speak about treatment of osteoporosis. Respected Manoj Kr sir, my senior colleague Dr. Rohit Mohpal. I would like to share my screen with you. Yes. Can I have a great view of this? Am I audible to everyone? Hello?
Yes,
Yes,
sir.
sir.
Yes, sir.
Okay.
Yes,
Great.
Yes, we
So
are.
I'll start with, as sir has already talked about osteoporosis and Rohit sir has already spoken everything about clinical features and investigation. I'll go for treatment of osteoporosis. Treating osteoporosis involves treating and preventing fractures using medicines to strengthen the bone. Diagnosis of osteoporosis is based on result of your bone density scan and the various other tests which Dr. Rohit Mohpal has already mentioned. Treatment. Decision about what treatment you need is based on a number of factors, including your age, sex, risk of breaking a bone, and previous injury history. Medication for osteoporosis. That includes bisphosphonates, selective estrogen receptor modulators, parathyroid hormone, monoclonal antibody medications, calcium, and vitamin D. Calcium is the main mineral found in bone. Balanced diet is important for maintaining healthy bones and for healthy adults. Recommended amount of calcium is around 700 milligrams of calcium a day. Which most of the people should be able to get it from a very varied balanced diet that contains good sources of calcium and or supplements. However, if you have osteoporosis, you may need some more calcium. Vitamin D supplements. During autumn and winter, vitamin D helps the body absorb calcium. All adults should have 10 micrograms of vitamin D a day. From about April to September, most of the people should be able to get all vitamin D they need from sunlight on their screen. Rest, as this picture shows, we can have salmon, raw milk, eggs, mushroom, tuna, sardines. These are all good source of vitamin D, and the best one is sun. Since it's difficult to get enough vitamin D from food alone, everyone, including pregnant and breastfeeding women, especially, should consider taking a daily supplement containing 10 micrograms of vitamin D. Now, second, bisphosphonates. Types of bisphosphonates. There are mainly two types of bisphosphonates, non-nitrogenous and nitrogenous. In orthopedics or osteoporosis treatment, we usually use nitrogenous bisphosphonates. They are anti-reabsorptive agent bind to hydroxyapatite crystal in bones, directly or indirectly invent osteoclast, that is breaking of bones, inhibit bone mineralization at sufficient doses, pharmacologically active only while on exposed to bone surface and remain bound in bone matrix for years. The mechanism of action is, as you can see in this slide, the osteoclastic activity is going on. So finally, the bisphosphonate drug stops this osteoclastic activities and osteoblast is building new bone, and finally the new bone is made. These are the few FDA approved bisphosphonates for osteoporosis. Alendronate, we can use it 70 milligram weekly or 10 milligram daily. Evandronate, 2.5 milligram daily or 150 milligram monthly. Resendronate, we can use 5 milligram daily or 35 milligram weekly. or 150 milligram monthly we can give. Zolitronate. This is given via intravenous route. 5 milligram once yearly. There are various side effects of bisphosphonates. They are given as tablet or injection. Always take this bisphosphonate on an empty stomach with a full glass of water. Stand or sit upright for 30 minutes after taking them. You will also need to wait between 30 minutes to 2 hours before eating food or drinking any other fluid. Bisphosphonates takes 6 to 12 months to work and may need to take them for 5 years or longer. There are adverse effects of bisphosphonates, which includes irritation of food pipe, swallowing problems, stomach pain. In some cases, osteonecrosis of jaw is seen. That's a rare side effect, but not very uncommon. The third one is selective estrogen receptor modulators. SERMs helps to maintain bone density, reduce the risk of fracture, particularly of the spine. Raloxifene is the only type of serum available for treating osteoporosis. It is taken as a daily tablet. The other serums are clomiphene, tamoxifen, chloromethane, and omilexifene. The adverse effects of SERMs are hot flushes, leg cramps, potential increased risk of blood clots. Parathyroid hormones. Parathyroid hormones produces naturally in the body. It regulates the amount of calcium in bone. Parathyroid hormone treatment such as teriparatide are used to stimulate cells that create new bone. Teriparatide is given as a subcutaneous injectable route in doses of 20 microgram per day for up to 2 years. While other medications can only slow down the rate of bone thinning, parathyroid hormone can increase bone density. Used in a small number of people whose bone density is very low and when other treatments are not working. Adverse effect of parathyroid hormone are very less, like nausea, vomiting, not much. It is very easy, comfortable, like it's given in an insulin syringe. As with insulin, we have seen everywhere we can see old people taking insulin. PTH also, all the various brands of teriparatide comes with a pen and an insulin, which can easily be administered by one itself. Hormone replacement therapy. This is one of the very important things. Hormone replacement therapy sometimes is taken by women who are going through menopause. It can help to control symptoms. HRT has also been shown to keep bones strong, reduces the risk of fracture during treatment. However, HRT is not specifically recommended for treating osteoporosis and is rarely used for this purpose. Adverse effect of HRT. This is because HRT slightly increases the risk of developing certain conditions like breast cancer, endometrial cancer, ovarian cancer, stroke, and venous thromboembolism, more than it lowers the risk of osteoporosis. So it's very less used, but this is what sometimes we use it. Monoclonal antibody, not very old. It has been recently developed, and till now it is not widely used. Denosumab. Monoclonal antibody. It comes with the name of Prolia. Denosumab inhibits the formation and activity of osteoclasts by blocking receptor activity of nuclear factor kappa B ligand. Dose of 60 milligram given subcutaneously every 6 months for 3 years. It significantly increases bone mineral density in postmenopausal women compared with weekly dosing of alendronate. Denosumab decreases hip, vertebral, non-vertebral fractures compared with low doses of calcium and vitamin D. Appears to be a reasonable alternative for persons whose condition does not improve with bisphosphonates. Renal insufficiency is a listed caution, but denosumab appears to be safe for patients with chronic kidney disease stage 1 to 3. Before starting denosumab, you should have a dental examination. You should continue to take good care of your teeth. See your dentist regularly while you are on denosumab. Make sure your dentist knows you are taking these medications. Don't forget to check the serum calcium level before you take denosumab, because sometimes after administering denosumab, patient lands in severe hypocalcemia. Adverse effects of denosumab: break or crack in middle of the thigh bone, delayed healing of jawbone, that is osteonecrosis of jaw. Osteoporosis, some facts I'll tell you. When we are at our age of 30, that age, you are at the peak of the bone mass. When we are at 50, age when bone loss increases, especially in women. 10 million number of Americans who live with osteoporosis, 44 million number of Americans who have low bone mass, and $19 billion is the annual cost of osteoporosis related to fractures. Three best way to prevent osteoporosis is get adequate amount of calcium, get adequate amount of vitamin D, exercise regularly. This is the last slide and very informative. Just look at it. 1 in 3 women and 1 in 5 men over 50 will experience osteoporotic fractures. Risks are genetic susceptibility, inactive lifestyle, age over 45, insufficient mass and growth. This is the normal bone, as sir has also shown, Dr. Manoj Kr Choudhary sir has also shown normal bone, and this is the osteoporotic bone. And prevention and treatment can be done by diet, dairy product, restful sleep, calcium and vitamin D. Limit your coffee, stop smoking, and take little of alcohol. That will help you to prevent osteoporosis. Thank you. Thank you so much. Yes, sir.
Thank you, sir, for this very enlightening session.
Thank you.
With this, we have now come to the end of this wonderful session. I thank Dr. Manoj Kr Choudhary, sir, Dr. Rohit Mohpal, sir, Dr. Gyan Ranjan, sir, for joining us. I am sure this session will prove to be very beneficial for our audience. Thank you once again. I would like to thank Dr. Rajnish Raj, President IMA MSN UP, Dr. Rahul Anand, Secretary IMA MSN UP, and the entire Stethify team for being the pillars of this workshop. Thank you to all of you for joining in. And if you missed the session or would like to watch it again, it will be available on our official YouTube channel, IMA MSN UP. You can also watch there. Thank you. Thank you again.
Okay. So, sir, it's time to leave for our another program. I hope any questions from the audience are welcome. You can come and ask. In fact, other than osteoporosis, if you need something to ask about post-graduation or things.
This was a wonderful session, and
Wonderful.
we could have done a bit. We could have expected some questions, but since we have to go for another webinar just now, it will be difficult for us to continue here. So it was a wonderful session indeed, and I thank the IMA MSN UP group that they have given us this chance to interact with you, and this shows your interest in such activities. Thank you, IMA MSN and the people in all the people involved in this group. Thank you.
Thank you so much.
sir.
Thank you, sir.
Yeah.
Thank you, Dr. Manoj. Thank you, Dr. Rohit. Thank you, sir.
Thank you. Thank you. So, sir, we'll move. Manoj, sir, we'll move to another BOA.
Thank you,
Or
moderator.
you want to ask any question? Just now I can see a young gentleman on the screen. IMA MSN UP. Yes,
Hello,
you
sir.
want to ask any questions? Thank you so much. Wonderful program. You should keep doing it.
Okay, sir. Thank you, sir.
I congratulate you all, the whole team. Very good. Very good, guys. Keep it up.
Thank you, sir.
Okay.
Okay,
Take care.
should I end the meeting?
Thank you, sir.
Yes,
Okay.
thank you.
Bye.
So this time we have kept it for a seminar. Definitely we will be arranging some Q&A seminar with it too.
Okay.
Okay.
Thank you.
Thank you.
Okay. Thank you, sir.
Thank
Okay,
you.
Rohit, sir. See you soon.
Thank you. Thanks a lot.
Okay, sir. I'm ending this meeting now.
Thank you, sir.